comfortable while we welcome our next debate. While everyone's shuffling, I will welcome my colleague, Dr. Rajan Gadia. Dr. Gadia is the Director of Acute Teleneurology at Houston Methodist and the Program Director of our Vascular Neurology Fellowship. Dr. Gadia, you get to referee the next debate.
Thank you, everyone. I have a bag of boxing gloves outside, so this is going to be less of a formidable debate. But I am delighted to invite our first speaker. This debate is going to be about mechanical thrombectomy in patients presenting with low NIH stroke scales or non-disabling presentations. I'm delighted to introduce one of our newer neuroendovascular surgeons, Dr. Alex Hoang. He's an assistant professor of neurosurgery here at Houston Methodist and specializes in cerebrovascular and neurointerventional surgery. He completed his neurosurgical training at The Ohio State University and neuro-IR training across the street at Baylor. His clinical interests focus on open and endovascular treatment of cerebrovascular diseases, including acute stroke, brain aneurysms, and brain AVMs. His research interests include clinical and translational research focused on stroke treatment and outcomes. He's going to talk to us today about the role of mechanical thrombectomy for low NIH stroke scale. No need to wait. So, Dr. Hoang?
Thank you for those kind introductions. I'm Dr. Alex Hoang from neurosurgery. So the debate today is what should we do with these patients with low NIH stroke scale acute ischemic stroke? And what I'm advocating for is direct to mechanical thrombectomy, and we shouldn't wait. So no disclosures. These are the 5 landmark trials from 2025 that really overwhelmingly showed the benefits of endovascular treatment for acute ischemic stroke for patients with large vessel occlusions. The inclusion criteria were mainly for patients with NIH stroke scales greater than 6, and it's been expanded to over 24 hours. But it remains really unclear whether thrombectomy benefits patients in patients with lower NIH stroke scales, and that's kind of the question we have today. This is a graph of patients presenting with M1 occlusions and their NIH stroke scale scores. And what you see here is that the median NIH stroke score is 14 for these patients. And the NIH stroke score of 10 has 81% positive predictive value for approximal occlusion with only 48% sensitivity, with a majority of these patients presenting with low NIH. So when you think about the distribution of patients that present with LVOs, a good number is below NIH of 6. Here's another histogram of patients that present with LVOs with ischemic stroke and whether they have an approximate occlusion or not. And you could see that a high initial NIH stroke scale score is associated with a large vessel occlusion, but many patients have a low initial NIH stroke scale score and are found to have clinically important large vessel occlusions. And 36% of these patients have a large vessel occlusion and present with an NIH stroke scale less than 6. And you could see here that in this group with an NIH stroke scale score of 0, these are the patients with TIAs, 29% of these patients have approximal occlusion. So it's not an insignificant number of patients who have low NIH stroke scale scores. So here's a tale of 2 patients here. So the first patient here has both patients presenting with M1 occlusions. One patient presents with mild symptoms while the other one is more severe. And the question I have for you is which one would you rather treat? Would you rather treat the NIH score of 3 or the NIH score of 7? So in this patient on the right who presents with just mild drift, this patient has excellent collaterals. You could see that there is reconstitution of the MCA through PO collaterals, and their deficit is low. But in this patient with an NIH of 17, you could see that there's a large vessel occlusion and M1 occlusion, but you could also see a lot of ischemic brain. So when you see this, in patients with proximal occlusions with lower NIH stroke scale scores, there's a particular clinical interest because the patients that is more likely going to benefit is the ones with the low NIH because they have a larger penumbra and a larger brain area at risk than patients with a higher NIH, and these are like the ideal candidates for intervention. So this patient with low NIH has more penumbra versus this patient which has a larger core. So, this is kind of a collateral score. So what you saw there was kind of a multi-phase CT, and it shows the extent of PO collaterals. And patients with poor collaterals are more likely to rapidly develop acute infarction and may be less suitable for endovascular treatment versus the patients that have higher collaterals and thus lower NIH stroke scale scores. So when you see a patient with an NIH of 3 and they look very good, and the question is it too good to intervene? And the question really kind of weighs the risks and benefits of the procedure. So, mechanical thrombectomy carries all the risk and expense inherent of an invasive procedure. And thus, the minimal clinical stroke severity justifying intervention really remains to be established. And, currently it's 6, but, there's a window of discretion. So when we think about weighing the risks and benefits, there's a risk of clinical deterioration. So it's important to look at patient selection, which patients would benefit, which patients wouldn't. And then there's procedural risk, which include the devices that we use and the procedures that we use to take out the clot. So which patients have a higher risk of deterioration? So this is a graph of cerebral autoregulation. And cerebral autoregulation is where the brain tries to maintain a constant blood flow throughout different cerebral perfusion pressures. And when we see an ischemic brain, the vasculature is maximally dilated because of the stroke. And there's a loss of an ability to autoregulate blood flow. And any changes in cerebral perfusion could be directly transmitted to a loss of cerebral blood flow. And cerebral blood flow is dependent on the mean arterial pressure. So, one thing that you could do in these patients is to do an orthostatic challenge where you could evaluate the collateral failure by elevating the patient in the stretcher and monitoring their examination. So you could elevate the bed for 5 to 30 minutes and observe for a worsening NIH stroke scale score. And a failure could be a failure in these patients would mean an intervention might be beneficial. So we kind of talked about patient selection, and then what about procedural risk? And this kind of graph shows the evolution of mechanical thrombectomy throughout time. And the first instance was the Mercy receiver back in 2004. And since then, there have been multiple iterations and multiple generations of aspiration devices, stent retrievers, and different technologies. And when you look throughout time, the complications of mechanical thrombectomy is hemorrhagic conversion, symptomatic ICH. And back in 2004, these devices had a higher rate of symptomatic ICH, from 11% and now down to aspiration. The current aspiration technology right now, the hemorrhagic rate is 1 to 3%. So as technology has kind of progressed, the procedural risk of mechanical thrombectomy has become safer as technologies have advanced. So I would say that the risk of mechanical thrombectomy may have a higher safety profile now than in the past. So these are 3 articles that kind of look at the natural history of these patients. So these are patients that have low NIH stroke scale, and they are treated without TPA. So in these patients that have low NIH, the clinical outcomes at 3 months are that 25% are unfavorable versus 75% that are favorable. And in these patients, when you look at the multivariate analysis, patients with approximal vessel occlusion, it's an independent predictor for unfavorable outcomes. So 25% of these patients do poorly, and patients with large vessel occlusions do the worst. And it's an independent predictor for poor outcomes at 3 months. This is from the same paper, and it looks at similar things. Patients that are younger and have a lower NIH do better. The female sex was a poor predictor for poor outcomes, and there were no significant effects for cerebrovascular risk, sites of occlusion, or presenting symptoms. When you looked at these patients that have low NIH and their risk for early neurological deterioration and infarction expansion, one of the biggest risk factors is having a present large vessel occlusion. So these patients with large vessel occlusions have an increased risk for early neurological deterioration, and they have poor outcomes with MRS greater than 2 I believe at 90 days. And then another measure of outcomes is disposition. So whether they are discharged home to a skilled nursing facility or hospice or death, you could see here that patients with basilar artery elbows do the worst. And here you see a linear relationship between NIH and the NIH stroke score and outcomes. And as your NIH stroke score goes up, your outcomes, you have worsening outcomes. So in conclusion, a significant number of patients with mild or rapidly improving stroke symptoms can decline, and these patients do end up with poor outcomes. And one of the biggest predictors of poor outcomes is a large vessel occlusion. So what about, these are 3 articles that kind of compare and contrast mechanical thrombectomy with medical management with and without TPA. In this first study here, these are patients that are consecutive patients that have low NIH stroke scale scores, less than 5, who have a large vessel occlusion on CT with an MRS, baseline MRS of 0 to 2. And in this study, there were 32 patients. 22 received medical management, and 10 patients received mechanical thrombectomy and intervention. And you could see here that 41% of these patients had subsequent deterioration and required thrombectomy. So a significant number of patients with these low NIH stroke scales, end up deteriorating and requiring thrombectomy. And the distribution of patients that got IV TPA were 60% in the thrombectomy group versus 9% in the medical group. And you could see here that thrombectomy really changed, really improved the outcomes. There's a significant shift in NIH stroke scale scores at 30 days, I believe. And at 90 days, the MRS, a good MRS was 100% in the thrombectomy group versus 70% in the medical group. And thrombectomy was independently associated with a beneficial shift in the NIHSS stroke scale score at 90 days. Here is another paper that shows, that really evaluates TPA in these patients. So this is 88 patients, patients with a large vessel occlusion with low NIH, and 50% of these patients received thrombolysis, and then, 50% did not receive any TPA, and then the other 50% received TPA with a combination of endovascular treatment or TPA and endovascular treatment. And what this shows here is that, patients that received TPA had better recannulization rates. Patients that received TPA had better neurological deterioration. And basically, so this is kind of what it shows here, that patients that had thrombolysis did better. And the reason why I show you this is that because patients with thrombolysis do better, I think for patients that aren't a candidate for TPA, I think endovascular treatment is critical for these patients. And the last article here shows, this is another paper that shows 54 patients, 14% received immediate endovascular treatment, 11% received treatment after deterioration, and then 74% received standard medical management with TPA. And when you look at the outcomes over here, at 90 days, patients that were in the mechanical thrombectomy group, there was a 75% MRS of 0 to 1 compared to 33% in patients that deteriorated and got thrombectomy versus the medical group, which is 55%. So across the board, mechanical thrombectomy had better outcomes than thrombolysis alone. So when we go back to this slide about, is the patient too good to intervene? I think we have to ask ourselves, what's the risk of clinical deterioration? And it's these patients with large vessel occlusions. Patients with good collaterals should do better because there's more penumbra. Patients with basilar arteries, occlusions fare the worse, and I think should go for thrombectomy. And then patients that aren't a candidate for TPA, I think these patients are excellent candidates for thrombectomy. And then when we look about the procedural risks, the procedural risks have improved with time. And there's two standard ways to do thrombectomy. One is aspiration and one is stent retriever. And sometimes a DAP and aspiration first may have lower procedural risk. And in conclusion, it's not uncommon for these patients to have a large vessel occlusion and low NIH. And ultimately, 25% do deteriorate. In these patients, when the collateral circulation, when the collateral vessels fail, these patients could have a large stroke, and these are the patients that would benefit the most from reperfusion.